Yakima Valley Community College Radiologic Sciences Program presents Radiographic Positioning. The cervical spine.
Cervical spine is the lesson of today. In today's era, with cost efficiency in mind, we actually do what is called a partial C-spine series. That would consist of a lateral and an AP and an odontoid or an open mouth AP. For purposes of teaching, I'm going to demonstrate multiple scenarios, or not multiple scenarios, I mean multiple positions or projections for you to do. So we will begin the demonstration with a lateral, and then we will do an oblique, and then we will, continue with what is called a swimmers, also known as a twining, and then we will do our AP and our open mouth odontoid shots. So we've got our room set up for a lateral patient. Let's talk about patient positioning or dress first. She will be in a lateral position, and our model elevated her hair for us into a ponytail. We don't have earrings on, and she doesn't have any, well, hopefully she doesn't have any body piercings. If you can, hopefully there's they call it a plug, Kristen, for the tongues. Okay, you would have a plug in there instead of the metal, because things are going to get in the way. Earrings need to come off. Make sure you practice with glasses not on the patient. Glasses wouldn't be into the cervical spine region, but they will definitely show up on your image, this little metal frame and then these ears coming back, and you'll get laughed at. So remove the structures. Hair is not normally into a pony. That will cause you a problem, but for demonstration purposes today, she's elevated her hair for us so you can see her neck.
Talk about dental.
Dental, yes. Ask your patient. You have to use a little tact, because dentures can kind of connotate aging, and some people might be a little sensitive if you ask them if they have any dentures. Ask any patient of any age if there's, I think the safe thing to say is removable appliances. It's kind of a universal term. Is there anything in your mouth that you can remove? Something like that. That can happen at any age. Young children with these flipper teeth to save a spot in case they lost a tooth till their permanents come in, or the elderly where teeth are with dentures. Make sure you put them in a safe spot. So we're going to have our patient stand. I could have them sit, but standing, the exam is fairly quick if they're a walkie-talkie patient, or I could have her sit, or in a trauma situation, which will be in a different lesson altogether, you may do these entirely recumbent in a trauma situation. I'm using the vertical board, and I have 72 inches SID. I have a 10 by 12 cassette into the wall bucky, ID blocker to the top. My patient's feet are separated so she has more mobility. Kristen, let's let them look at you for a second. Elevate your chin. Take a look at the space between her chin and her shoulders. There's quite a bit of space. Study your patients. Many patients have short necks. A patient with a short neck is going to cause you a little bit of concern, because it is absolutely necessary that you demonstrate C7. And when I say C7, you should automatically assume the adjacent bone, which you need part of T5. You need the joint space between C7 and part of T5 on there. And somebody who doesn't have a short or doesn't have a long neck, this shoulder is going to be right over that 7th cervical vertebra. So you're going to work on getting the patient's shoulders relaxed. And I'm going to put sandbags out here. I don't recommend the use of sandbags on every patient for personal reasons. My sister, small in stature like Kristen was, they gave her weights to hold for the lateral, and she was so small that these weights, which can be 5 to 10 pounds each, actually caused motion on her. And she had long enough neck to where her shoulders weren't a problem. So giving patients weights on a routine basis might cause you a problem with motion issues. But I'm going to show you how to use those just in case you do have a patient with big shoulders or short necks. Because if you don't demonstrate C7, like I said, you will have to do something to get it demonstrated. Okay. So the patient's going to be in a true lateral position, feet are spread. Look at the shoulders and the hips, just like we've done with every other lateral scenario. And have your patient step forward until the mid-coronal plane, a little bit more please, is right to the center of the film. See, this crosshair is coming right down the center of her neck, just anterior to the EAM. That will be a good indication for you. Have the patient elevate their chin, not too much. You don't want them looking way up. That would be called an extension. And if they're looking down, this would be called a flexion. Now, sometimes you will do flexion and extension positions. They would be just like what I'm demonstrating here, but you would have the patient really extend or flex. That would be checking for mobility reasons. Okay, so elevate the chin. So they're just like the infraorbital meatal line is parallel, the chin is parallel to the floor. And I want this crosshair coming in right at the level of C4, which is just above the Adam's apple, just above the bump. So I need to elevate my tube a little bit and my film. Now you can use the center of the film at C4, or you can use the auricle of the ear, the top part of the ear. You want the film's edge 1 inch above the auricle of the ear. And in Kristen's case, the CR is to C4 and my film's edge is actually 1 inch above the top of her ear. So I am very confident that all C7 vertebrae will be demonstrated. Step forward, please. And the last thing I want you to do, if the camera can focus on the board here, to look at the amount of collimation and the shadow of her neck. See the shadow of her neck right down the center of the board? Okay, does that help? This is going to let me know that I can tighten up that collimation a little bit more. It will also let me know, Kristen, would you step back? If you look at the shadow of the board, most of the shadow is behind the photocells. This is going to cause you a positioning problem and a technique problem. Or if she's too far forward, that is not good positioning either. You want the neck right down the center of the board. And I'm going to tighten the collimation a little bit. Leave your length, but the neck will dictate side to side how much collimation you have. And then you can, once you determine your collimation, you can put your L marker on the board. And the last thing you do is you come to the front of your patient and you make sure they're looking straight out at you, so they're not rotated. Again, you want them looking straight out at you. You don't want the head tilted and you don't want the head turned. You need to be looking straight out at you. I'm looking at her eyes to the lateral edge of the skull, and I'm making sure she's not tipped. And this would be C7. This would be a lateral cervical spine. You need all C7 on there. If she has big shoulders, just before you make the exposures, do not have them hold the sandbags any longer than necessary. Just before you make your exposure, give them the sandbags and tell them that they need to relax their shoulders. You can actually have them take in a breath, blow it out. Do that yourself and feel what your shoulders do. They actually relax down. And then C7 might be better demonstrated. Okay, we can have the sandbags now. If you've done a good job on a lateral cervical spine, you elevate the chin. That will get the rami away from the cervical spine. And if she's in a true lateral position, the rami of the mandible will be superimposed. One won't be forward and one won't be back. And then your zygapophyseal joints will be well demonstrated. And that's the criteria for a lateral C-spine, making sure all C7, 1 through 7 are on there, and inclusive of T1. Let's do a swimmer's next, just in case. Let's pretend we had this big shouldered patient or somebody who was injured and they couldn't relax their shoulders. Again, try to have the patient reach for the ground. Explain to them that you must demonstrate all of the cervical vertebra or you will be having to take the x-ray over again. Try the sandbags. Let's say you've done that and you still have not demonstrated all 7 vertebrae. Well, here's an alternate. It's not the ideal situation. Its purpose is to demonstrate C6, C7, T1, and T2. It's called a swimmers. The real name for it is a twining. But swimmers is what we use because it's so descriptive. You're going to be putting her into a swimming position, one arm up, one arm back. Okay? So they can see better. We're going to not do, normally you would do a left lateral, but so you could see better, we're going to flip the patient around. Again, this is an alternate. You have to demonstrate C7. You couldn't do it any other way. We're going to do a swimmer. She's fixing her shield for me. I'd be having a right marker on there. You're going to be using the 10 by 12 again. Same SID. And think of swimmers. One arm up, one arm down, one arm forward, one arm back. Okay? Now you want to keep her into a lateral position. So I want her in her thorax in a lateral position, checking her hips and her shoulders. And then this arm closest to the board comes up, raises this humeral head, but notice how it's going to be underneath the cervical spine too. So that's why this is not a primary one. This is a backup one just to get C7. Make sure there's no problems with C7. And then this arm is relaxed and down. Okay, that's the position of the patient. I've made sure she'd stayed lateral. One arm up and forward, this arm down and back. Elevate the chin. And let's verify our centering. You want that crosshair coming right down through the neck here. Okay, at the level of C7, because now remember this one's after 6, 7, T1, and T2. So I can lower the central ray down over C7. And how would you know where C7 is? You can feel for the cervical prominence. The bump on the back of your shoulders, feel for it. The one that's most prominent is C7. That's where I want the crosshair coming down through. Okay, right there. And so I'd fix the vertical board to match. And then you look at the patient's face because you want them, again, straight and not rotated. Now, I want you to focus right here on this crosshair too. Again, it's coming in at C7. And we're happy with that. What if Kristen did have those bigger shoulders? This shoulder may not come down so much. Okay? We're kind of mocking the scenario now. See how the crosshair is not clearing that shoulder? There it's clearing it. There it's in the way. You might have to put a 5-degree caudal tube angle on this if you didn't clear the shoulder. Put a 5-degree caudal tube angle on there. I think the camera can see. And you'd have to fix the adjustment to come down through C7. But see now how we're clearing that cervical vertebra? Again, her shoulder stayed up. I'm trying to mock something. If you can't clear the shoulder, put a caudal tube angle on there. Okay. Head again, stay straight and no rotation. And I think the camera got a pretty good look at the twining position here. Again, this is not routine. It's only if needed to demonstrate C6 or 7 or T1 or T2. You can relax. When we teach you the thoracic vertebra, you will learn that T1 and T2 hardly ever show up well on a lateral T-spine because, again, of the shoulders. And if there is a suspicion of fracture over T1 and T2, and your focus is the thoracic spine, a twining is an alternate to a lateral thoracic spine as well in order to see T1 and T2. Okay, so we're going to go back into we took the lateral, a normal lateral. We took a normal lateral, and now we need to do our obliques. The oblique has a 15-degree caudal tube angle. Obliques have a 15-degree caudal tube angle. Kristen, let's do a right oblique so they can see you better. You end up doing both obliques, class. You will have to do both obliques because the oblique is to demonstrate the intervertebral foramina. We choose to do RAOs and LAOs. We choose to do the PA obliques with patients in an RAO or an LAO position because we want to demonstrate the intervertebral foramina closest to the film. And I think the camera has a better angle looking at you now. 15-degree caudal tube angle helps to open up the intervertebral foramina. You want it entering at C4, again, just above the Adam's apple, exiting to the center of the film. I'm going to mark the downside. I'm going to use an R marker and put it on her downside. And again, I'm going to look at the shadow of the neck on the board and have my patient step a little more forward, and she's at a 45-degree obliquity. Shoulders relaxed because you need C1 through C7 again. Look at the shadow of the board, get the neck centered. You have an R marker in there, 10 by 12 cassette, lengthwise ID to the top. RAOs demonstrate the right intervertebral foramina. You use a right marker on the right side. The tube is angled 15 degrees caudal. Chin, last thing you want to do is elevate the chin and have her head straight. Okay? This keeps the head into an anatomical position. The body is at a 45-degree oblique. Okay, Kristen can relax for a second. Okay. A lot of techs choose not to do a patient in an anatomical position. Remember, I just demonstrated the anatomical position. That means the face and the head stay together, patient's looking out straight. Some techs choose to actually turn the face a little bit. Why don't we discuss the pros and cons? What do you think? Okay. In an oblique position with an anatomical position, 45-degree oblique, the face remaining with the body, the intervertebral foramina of 1 and 2 are better demonstrated in an open position. But the disadvantage of this is actually the mandible will actually superimpose over the spine. The mandible will be over the spine. So some techs choose to compromise the openness of the intervertebral foramina a little bit and turn the face into a lateral mode so the face is looking straight out at you. The disadvantage of this is they tend to close the first and second intervertebral foramina, but the advantage is the fact that the mandible totally clears the spine. As your teacher, you can relax, Kristen, as your teacher, I'm not going to tell you which way you should do. I will expect you to know the advantages and disadvantages of either one of those ways of doing that. Again, if the head is in an anatomical position, you better demonstrate the intervertebral foramina open. Disadvantage is the mandible is over the spine. And if the head is in a true lateral position, you tend to close up the intervertebral foramina, which was your purpose in the first place, but the mandible is not in the way. In either case, do not tilt the head. Whether it's anatomical or lateral, do not have the head leaning in. And when you look at an X-ray image, you expect the intervertebral foramina to be open, and the mandible, the edges of the lower mandible will be at the same level. And depending on whether the head is anatomical or not, if the head is anatomical, you'll see one mandible forward and one mandible back. And if the head is in a lateral position, the entire mandible will be superimposed. So I'll be expecting you to recognize either way and justify why you choose one way over the other. Now let's it really helps to see the body here, Kristen. If the intervertebral foramina are not opened, ladies and gentlemen, if they're not opened on your X-ray image, and you see a lot of the lungs, and the ribs are laid out, and you see clavicles laid out. See Kristen's body, you're going to see lots of clavicles. That means the patient wasn't obliged enough. You need to oblige her more. Okay? Now, if the intervertebral foramina are not open and you see mostly shoulders, white over the shoulders, and the clavicles aren't laid out, and you don't see a lot of lung laid out, she was too steep, and you need to lessen the degree of obliquity. And that's the oblique. Okay? Again, do both sides. Do both obliques. If you're shooting PA projections, the patient is in an RAO or an LAO position, and you are demonstrating the intervertebral foramina closest to the film. The ART, they may ask this question, or you actually will perform anterior, posterior projections with the patient in an RPO or LPO position. Remember, when the patient reverses, the criteria reverses. We had a caudal tube angle with RAOs and LAOs. So if you did LPOs or RPOs, what direction would you angle the tube? Cephalic, not caudal. And if you were demonstrating the downside, like we did in the scenarios I talked about here, if the patient is reversed and you're doing posterior oblique positions, you're actually demonstrating the upside or the wayside. Okay. We need to pause now for a minute, and we're going to get the patient set up on the table for our last two projections, an AP and an open mouth. We'll be back shortly. You could actually continue the cervical spine series at the vertical board, but for the demonstration purposes and better camera angles, etc., we've converted the patient to the recumbent position. And your vertical boards may or may not allow the flexibility of continuing the series in that way. So seeing this on the table is beneficial too. And you can decide, again, like we said, anything you do vertical, you can do recumbent or vice versa. So we're going to look at our patient now. She's in an AP position, and she's straight on the table. She's shielded. I have tentatively set up a 15 to 20 degree cephalic tube angle for my AP projection. This is an AP, straight AP projection. I have an approximate 15 to 20 degree cephalic tube angle. What we need to do now is have the patient open her mouth, and I'm feeling for the mastoid tip, the very tip of the mastoid process here, and I'm drawing an imaginary line to the inferior border of the superior teeth. Inferior border of the superior teeth, the bottom of the top teeth, in other words. And after you practice, you'll be able to just visualize this, but I'm going to use a straight edge here. Here's your mastoid tip. Keep both of your eyes open, because if you close one eye, it kind of shifts things. And her teeth and her mastoid tip are lined up. So I'm happy with that position. I ask the patient to close her mouth, but do not move her head. Make sure you pay attention to the head, because as somebody opens and closes their mouth, they might tip their head forward or back. Now what I'm going to do is, remember I told you I had a 15 to 20 degree cephalic tube angle. I've put the crosshairs of the tube over her mandible so you can see here. And here's the trick. You want the tube angle to match the angle of the mandible. And I'm a little bit too much angled with my tube, so I'm going to lessen that degree of tube angle just a little bit. And then I will be more in alignment with the angle of the mandible. And when I look at my gauge, I have the 15 degrees. So I'm going to adjust my vertical board, the vertical lock rather, to maintain 40 inches, so I have 37. And then I want the crosshair to come in just above C4. The bump of the neck, just above it, puts me at C4, exiting to the center of the film. Right marker on there, in a ways, because I'm going to collimate. And the last thing you have to do is come to the head of the table. Her MSP is to the center of the film, and I make sure that her skull is straight. and that the MSP of the skull is not rotated. I'm looking at her eyes out to the side, and that would be an AP projection. Let me emphasize the main points again. You will angle the tube 15 to 20 degrees cephalic. You will align the inferior border of the superior teeth with the mastoid process. You validate that the tube is at the same angle as the mandible, and then you enter just above the Adam's apple at the level of C4, exit to the center of the film, MSPs to the center of the film. You have 10 inches of collimation lengthwise, and side to side will be dependent on the patient's neck size. Come in fairly close, but do not clip pertinent anatomy. Step to the head of the table and make sure that the patient's face is in a true AP position. Make sure it's straight and that the distance from the outer canthus to the cheeks is the same on both sides. If you've done a good job here, the sternoclavicular joints will be symmetrical just like they are on a PA or an AP chest. And then we're going to be talking about the angle of the mandible. The distance from the angle of the mandible to the thoracic spine is equal on both sides. If the face is turned, see how the face can turn, but her thorax didn't. So this would be an example of the sternoclavicular joints being symmetrical. But the space here, the mandible will be further away from the spine on this side as compared to that side. And that would cause you, that would be evidence that you took the projection in a rotated position. This would be your AP. And we have one last projection to do. The patient basically stays in the same position for the AP and the open mouth. What you do change is you do not have a tube angle on the open mouth odontoid or open mouth AP. So you go vertical, you adjust your SID back to 40. You're going to be centered over the mouth with tight collimation. Change cassettes, line things up. Patient opens their mouth, mastoid tip, inferior border of the superior teeth. Kristen, can you tuck your chin just a little bit? Very good. Again, mastoid tip, inferior border of teeth. Once you have that lined up, patient, just move quickly, center right over the patient's mouth, the crease of the mouth. Patient's holding their mouth as wide as they can, and again, you make sure that the MSP is to the center of the film, patient is straight, and that there's no rotation, no crooked head, and that the distance on the two sides of the face is equal. And you make your exposure. Some techs will ask the patient to make the ah sound. If the patient can make the ah sound, the tongue tends to drop down a little bit more. This is the one that I was referring to at the beginning of the procedure about needing a tongue ring, a plug. The tongue ring will be right over the spine. If you've done a good job on this position, the base of the skull will be superimposed with the inferior border of the superior teeth. Base of skull will be lined up with the inferior border of the superior teeth, and then you will well demonstrate the odontoid process. The zygapophyseal joints on the two sides will be opened and clear, and the dens, the C2 dens, will be clear of superimposition. You'll be able to demonstrate it. And then you check for rotation. You look at the mandible and the distance between the mandible and the cervical spine and make sure it's equal on both sides. If you have positioned the patient, let's mock that, Kristen, with the chin elevated like this. The base of the skull is going to be lower than the teeth. The odontoid process is not going to be cleared, class. If you don't have the odontoid process cleared, you have to look at the base of the skull, its relationship to the teeth. And if the base of the skull is low and the teeth are high, to fix the problem, you tuck the chin. Okay? And then on the same token, if you've done it the other way, if the chin was too tucked, like that, the teeth will be lower than the base of the skull, and you have not demonstrated the dens, you need to elevate the teeth. You need to elevate the chin to get the teeth higher to clear the odontoid process. Okay? And then check for rotation. The industry today, a very common procedure or common projections used for a cervical spine procedure include the lateral, an AP, and the AP open mouth or the odontoid shot. Additional views that you might do, the twining was used when we did not adequately demonstrate the space of C7, joint space, T1. And the shoulders, there was nothing you can do to get rid of the shoulders. You do the twining position. You might also do that twining if you're after T1 and T2 and did not demonstrate that on the lateral thoracic spine. And the obliques, if they are part of the routine procedure, then you will do both obliques, either both anterior obliques or both posterior obliques, and they're to demonstrate the intervertebral foramina. And that's a summation of today's lesson.